Hey everybody, welcome aboard. We are going to give it just a second here before we jump in and get started. We are going to be talking about disc herniations, what to do, what to avoid. And basically, I just kind of randomly decided to go live on this one because I need to record it as a podcast anyway. And I figured why not do it in a way where you have the opportunity to ask me questions anyway. I will release this as a podcast soon, but I want you guys to have a chance to ask me questions live as we go through this stuff so that I can address your biggest concerns. Cool. So I think I'm going to start doing this more commonly moving forward. I'm going to try to record the podcast episodes that I release, and just while I'm recording those, I might as well go live, because then if you guys have questions, you can ask those questions. Okay. So let's dig in here. Let's see what we got going on. Awesome. I recognize a couple of people from our program, Nick, Byron, welcome aboard. So yeah, this is just going to be a podcast episode. If you're in our program, there's going to be a lot of stuff that you have already seen before, but I'm going to reiterate the important things that most people are freaked out about with disc herniations. And then if you have any specific questions, then I'll make sure to address those as I go through this live. Okay. So let's dig in. On today's episode, we'll talk about disc herniations. We'll talk about 5 things that if you have a disc herniation, you should be avoiding these 5 things. Now, most of the time, if somebody says, oh, avoid these things, you're thinking avoid bending, avoid lifting, avoid twisting, avoid exercise, avoid certain types of exercise because it's bad for disc herniations. So this is going to really challenge a lot of that typical dogma that is not evidence-based, by the way, and help you to move forward with your recovery, even if you do have a disc herniation or protrusion, or even something severe like a sequestration. But if you have a disc injury and you're a little nervous about it and you want to know what things you actually do need to avoid to keep yourself safe, and the things that you're taught to do, which are actually making your pain worse, and how to stay on track without as much fear, then this episode is for you. So we'll be talking about red flags, what to watch out for that is serious. We'll talk about rest versus exercise. We'll talk about the doom loop that people get sucked into, and fear, and how it just takes over and makes pain much worse long term. We'll talk about different symptoms to watch out for along the way, and how to know that you are exercising safely. And we'll talk about core stability, a lot of people's favorite exercises, and how the most popular exercise approaches for back pain and sciatica are often steering people in the wrong direction. Okay, so let's dig in. The first thing that you really need to avoid if you have a disc herniation is red flag symptoms, right? Meaning, if there's one thing that you should actually pay attention to, you don't need to necessarily worry about these things, but these are really serious things that you should be watching out for. It's going to be red flags. So red flags include things that indicate cauda equina syndrome, or non-musculoskeletal causes, or what we call specific causes of chronic back pain or sciatica. So if you have partial paralysis of the foot and you have not been evaluated by somebody to see how the weakness is, like how severe is the weakness, is it progressing and getting worse and worse rapidly? If so, definitely want to get a proper assessment on that. However, I will say, even with that as a red flag, a lot of times we see people with foot drop, and all we have to do is monitor it, make sure that it's not getting worse, work on strength, put together a proper recovery program, and oftentimes that foot drop will reverse itself with time and proper rehab. But it's something to get evaluated. So foot drop, partial paralysis of the foot. The other red flags for cauda equina syndrome are numbness and tingling in the groin, like you can't feel it after wiping when you use the restroom, or incontinence, that would indicate saddle anesthesia. So, saddle anesthesia is the numbness and tingling. So incontinence, new and unexplained incontinence that came on the same time the pain came on, and you're losing control of your bowel or bladder. Even sometimes people have and I'm just going to be direct and explicit here, but a little bit of dribble or a little bit of leakage. That's definitely something to talk to your doctor about, but that doesn't necessarily mean it's a red flag. These are things that are just, it's a red flag to talk to your doctor about. Okay. But as long as we rule those things out, or at least have them evaluated for severity, and your doctor says, no, I think it's safe for you to pursue and at least attempt a non-surgical rehab strategy, then you're good. Basically, the rest of it, all the other, like, avoid this, stop doing this, this is dangerous for disc herniations, all of that other stuff really is just fear mongering. It's not substantiated by evidence, and we don't need to be super afraid of our body. As long as your doctor has done a proper evaluation and ruled out red flags, then we have a really good chance that we can recover from disc herniations, back pain, and sciatica without having to need invasive treatments or surgery. Okay, so that's red flags. Next, avoid rest. The second thing you need to avoid is rest, specifically bed rest. Now, a lot of people, especially when they first have a major flare-up, they think that they need to just lay down, take it easy, don't move, don't do anything, don't be on my feet, don't bend, don't lift, don't twist, basically don't do anything. The problem with that is, even though it intuitively makes sense, you say, well, if it hurts, I should stop doing it. But long term, if that becomes the habit, then the more you avoid activity, the weaker you get, and you lose your mobility, you lose your strength, and then you're less capable of doing normal daily activities, which leads to more pain and more sensitivity, chemical sensitivity, inflammation, hypersensitivity, central sensitization, peripheral sensitization, and a lot of these, what we would call nociplastic or neurological changes that heighten our pain response. Essentially, they mean that it results in lots of pain even when we're not causing ourselves damage. So if we avoid activity, right, and we rest too much, then we fall into the category of doing too little for too long. And that leads to bad places. All of our best clinical practice guidelines, which are basically summaries of all of the evidence on treating a certain condition, in this case, chronic back pain and sciatica, clinical practice guidelines explicitly recommend against bed rest. Okay, so we don't want to rest. But we don't want to push too fast either. We don't want to skip steps. We don't want to do too much too fast. Okay, we got to find the Goldilocks zone. I'll get to that in a second. I'll talk about symptoms to watch out for and how to know if you're pushing at the right pace. The next thing that we want to avoid is the doom loop. Now, I already kind of described that doom loop. Basically, pain or injury leads to fear. Fear leads to avoidance. You're avoiding doing activity. And avoidance leads to weakness and deconditioning, which leads to more pain. And then we go back to the start, where pain leads to fear, avoidance, weakness, deconditioning, and more pain. If we get stuck in that cycle, it's really hard to get out because the fear is legitimate, but the reaction is unhelpful. If we avoid everything, we become weaker. It's a self-fulfilling prophecy. So it's okay to understand that, yes, we want to modify or limit or change our activities for a short time, but we don't want to just fall into the trap of avoiding activity forever. We want to break that doom loop. One of the things that feeds the doom loop is fear due to what we would call pathoanatomical thinking. Pathoanatomical means pathology, or quote unquote disease or ailment. And then anatomical, obviously the anatomy, the structure, bones, joints, discs, nerves, that kind of stuff, muscles. If we assume that pain always can be 100% blamed on a single anatomical structure, then it logically follows that if I'm causing pain, I must be causing damage to that anatomical structure. And if you're in the, doom scroll of, you're on your phone, you're scrolling through Instagram, you're watching things on YouTube, and everything is pointing to this muscle or that joint or the disc herniation or the nerve and scaring you and telling you the reason you have pain is because of this anatomical structure, that's going to freak you out. And it's a very outdated methodology of how to approach back pain and sciatica, or really any type of chronic pain, because we know that the longer that pain goes on, the more likely it is that there are multiple overlapping factors. Even if you have a disc herniation or stenosis or scoliosis or nerve impingement, even if your pain started with a severe injury, you were deadlifting and you felt a pop and your legs gave out on you, even with clear telltale signs of mechanical overuse, it may be true in the beginning that you overdid it and you hurt yourself. But long term, we find that the longer the pain goes on, the less likely it is that the physical abnormalities or the things you see on your MRI or your postural asymmetries are actually causing your pain. And the more likely it is that we've developed neurological changes or nociplastic, like, neuroplasticity. Your nervous system is very adaptable. Your immune system changes. It heightens its alarm response, and we have more pain. So the longer the pain goes on, the more likely it is that we have non-structural factors contributing to our pain. Okay. So we got to break the doom loop. We'll talk about that in just a second. Okay. How do we do that? Stop watching videos that tell you that your anatomy is scary and that everything's going to blow up if you bend your spine. Okay. Stop that stuff. And then start exercising slowly. Okay. The fourth thing that we want to avoid is certain symptoms that we would call unsafe pain or unhelpful pain. So specifically anything that makes traveling sensations down the leg worse. So I'm going to briefly cover what we call our safe pain protocols. Those of you, I actually see a couple of you that are actually in our program that are on this live stream. So you guys should be familiar with that. But for everybody else, our safe pain protocols, we have 3 protocols. We've got our traffic light, our no worse principle, and centralization. Traffic light, green, yellow, red. Green means go, yellow means slow down, red means stop. That's during activity or during exercise. It doesn't have to just be exercise. It could be mowing the lawn or getting groceries or driving in a car. Anything that you're doing that's, that creates pain, we want to use the traffic light to see if you're doing too much of it. Or if you're babying yourself and avoiding it, you get up and you feel a little bit of 3 out of 10 pain immediately. And you're like, ooh, I shouldn't be on my feet. No, it's fine. Keep walking. But if it starts to creep up to a 5, 6, and definitely a 7 out of 10 pain, let's take a break. Okay. That's our traffic light. Our no worse principle is that if it's getting worse and worse and worse, the more that you do, let's go ahead and ease off before we get to that red light territory. Or if it's worse, sometimes people have delayed pain. So they have pain that evening or the next day. Sometimes it's even several days after. And sometimes it doesn't happen for weeks or even months, where it feels okay. We're starting some new exercises, some new activities. I think it feels okay. A week goes by. I think maybe it's irritating me a little bit. 2 weeks go by. Ooh, dang, it's getting cranky. Okay. We looked at the data over time and our pain is increasing consistently over time. All right, something that we're doing is irritating. So we have to go back and figure out, what were you changing? How are your exercises different? Are we overloading or overtraining? Are we going a little too fast with exercise? Maybe you're just not recovering as well. So your sleep or nutrition or stress is not doing well. We got to figure out what's happening there. Okay, so that's our no worse principle. And then our last thing is centralization, which is it could be green light pain, or it could be, not getting necessarily worse. But specifically, if we're triggering any kind of significant pain or numbness or tingling or weakness in the foot or heaviness or other types of nervy symptoms down into the leg or into the foot or into the toes. We don't like that stuff. We don't like irritating nervy symptoms. So if it's significantly irritating those symptoms specifically, we would try to modify and find different activities or different exercises, or reduce the number of sets or reps or range of motion that you're doing. Or again, look at other lifestyle factors, stress, sleep, nutrition, to figure out why that's happening and then modify around it. Okay, so we need to get exercising. All right, that's the fourth thing. The fifth thing that we need to avoid is falling into this obsession with core stability and corrective exercise. Now, this sort of piggybacks on something that I said earlier, which is that the doom loop that we get into is fed by fear that comes from pathoanatomical thinking, that you have pain because of something wrong with your anatomy or alignment or asymmetries. So if you follow that line of reasoning and say, oh, I must have pain because of the disc herniation or my tight psoas or my tight piriformis muscle, and that's the entire reason I have pain, then it follows that the solution to that pain must be to fix your alignment or fix the disc herniation or loosen up a tight muscle or strengthen up a loose muscle or something similar, okay? That goes around and around in circles forever, all right? Nobody is symmetrical. You will always be able to find another area of asymmetry or imperfect mobility, strength, imbalances, etc. So that is a game that never, ever ends. It's an impossible goal. It's an unattainable goal. You will never be symmetrical. Now, I'm not saying that we shouldn't address the fact that, like, if you try to get up from a seated position and you literally can't put any weight on your symptomatic side, that's an obvious asymmetry. But the fault in logic is to assume that we need to fix the asymmetry in order to fix the pain, when in reality, the only reason you're asymmetrical or you're walking funny or you're leaning off to one side while you're walking or you're limping or something like that, the only reason you have the asymmetry, most likely, is because you have the pain and you're avoiding one side just because it hurts. So if we fix the pain, the asymmetry goes away on its own. That's one scenario. Now, the other scenario, some of you are like, no. I've been really asymmetrical for a long time. Well, okay, then you're actually proving my point that the asymmetry doesn't really have a big impact, because if you've had an asymmetry for a decade or maybe your whole life, right? Maybe most of your life you've been a little bit asymmetrical. I have. One of my feet, my right foot points outwards. It's a little externally rotated, not just a little bit. It's like significantly externally rotated. You can see it when I walk. But it's the bone structure, right? I have tibial torsion, right? And a little bit of femoral torsion as well. And it's because of asymmetrical sports and asymmetrical sleeping positions while my growth plates were not fused as a child. And so I look asymmetrical, but I will never fix that. That's impossible. And if I tried to force myself to fix it, it would probably just cause a lot of other issues anyway. So the asymmetry, if the asymmetry has been there forever, or at least a long time, then we still are left with the question, why did pain develop now or whenever it started? Why did the pain start when it started? If you had asymmetry for a long time before then, why did the pain suddenly start at this time period? The asymmetry didn't change. So why pain now? And usually, if we talk to people and get to know you a little bit, what we find is one of three things. One, you're doing too much too fast. That could be exercise or activity. So too much too fast after a period of doing too little for too long, or you're just like overtraining in general and you never take a break and you don't really rest and recover. Or the opposite, which is too little for too long. You're babying yourself. You're not really active. So it's just easier for you to trigger something and have pain. So it's either a too much or a too little thing, usually, or a back and forth thing. And if it's not that, which it usually is, but if it's not that, then oftentimes we have a lifestyle thing, which comes down to stress, sleep, and nutrition. If you're treating your body terribly, you're not going to recover well. What do you expect? If you're eating poorly, not really sleeping, you have tons of stress or life events or trauma or grief, you've lost people in your life, big life changes, things like that. What do you think is going to happen to all that? You think that your body is just going to have no reaction to those huge life changes or poor recovery for a sustained period of time? In fact, this is a really, really common thing. The amount of people who have lost a loved one, ended a significant relationship, moved across the country, and suddenly they have chronic pain and they're scratching their head like, why do I have chronic pain? You just went through hell. Your body, your mind, you just went through a lot. Of course you have pain. So we need to avoid this trap of getting hyper fixated or obsessed with, fixing your alignment, fixing your posture, fixing the disc herniation, unless there are red flags, because those things are most likely not as big of a factor as you think. Two, they don't, if you endlessly chase posture and asymmetry, you're distracting yourself and wasting your time doing baby exercises that don't actually progress you towards full body strength and mobility to live normal life. So forget doing baby exercises. Let's actually focus on living real life and getting you strong, right? And I had one other point that I was going to mention. That's okay. Maybe it'll come back to me. But we don't want to go down that road. We don't want to get hyper obsessed with core stability and corrective exercise, because it's not super important. So instead, we want to understand that. Oh, and this is my last point. I remember. If you are still unconvinced and you're like, no, Anthony, I've got to fix my posture. I've got to stretch my psoas, blah, blah, blah. Okay. You know what the best way to make sure that you have good hip flexor extensibility and glute strength, and that you stretch your piriformis and loosen up your, quadratus lumborum and all these specific muscles that you're worried about? You know what the best way to do that is? Just look at full body mobility and strength and progress it over time. Because if we're actually looking at full body mobility and strength, we're going to be doing flexion and extension and rotation and side bending. And we're going to do hip mobility and hip strength and loosen up the pelvis and all that. We're going to address all of those muscles anyway, but we're going to do it in a way that doesn't stress you out. And it's way simpler because you don't have to think about which specific muscle is the magic fix or disease or whatever, right? We can just focus on improving our whole body fitness. So we accomplished the same thing with none of the, I guess, panicky, like hyperfixation and stress that goes into corrective exercise. So it's a better way to do it anyway. Okay. So today we talked about 5 things that you need to avoid if you have a disc herniation or disc injury. All right. Number 1, look out for red flags. Have it evaluated. Go to your doctor and make sure that they clear you for a non-surgical approach, because there are some serious things, but they're incredibly rare. Okay. Number 2, avoid rest. Don't baby yourself. All right. Number 3, avoid the doom loop, which is that pain leads to fear, leads to avoidance, which leads to deconditioning and weakness, right? Loss of your mobility, loss of your fitness, which ultimately leads to more pain. And then the cycle goes over and over again. A lot of that comes from fear. So don't give into the fear and don't get obsessed with anatomy. All right. That's not, and I'm an anatomy teacher. All right. Like even when I was doing my doctorate, I was a TA, and now I teach anatomy. Like anatomy is really cool, but it just kind of freaks people out when we're talking about chronic pain. So it's not the answer. Move on. Okay. Number 4 is avoid worsening symptoms that do not abide by our safe pain protocols. Okay. So we got our traffic light, no worse principle, centralization. Get familiar with those. And then number 5 is don't get obsessed with core stability. In fact, a lot of people, we need to teach them to relax their core, breathe into your belly, chill out, Don't brace all the time, right? That just creates extra tension and fear. Not to mention that the joints in your spine need to be able to move to hydrate themselves and heal and feel better. So don't get obsessed with corrective exercise. Don't get obsessed with core bracing or any of that stuff. Just focus on full body mobility and strength progressions, and then use that extra mental bandwidth to improve lifestyle factors like stress, sleep, or nutrition. Okay. Remember, motion is lotion, movement is medicine. We want to move our body every day. There is a starting place for everybody, no matter how debilitating the pain is. And if you need any additional support from us, you can always watch our masterclass. The link is always in the description of our videos and podcasts and all that kind of stuff. And if anybody needs additional like one-on-one support, you can always book a call, talk to me. I'm happy to get to know your situation and see if we can help. That's it for today's episode, and I'll see you next time. That said, if you happen to be joining me live, that's gonna be a podcast. So if anybody has any questions, feel free to shoot them off in the chat. I'll hang out for a second, and just if you have any questions, I'm happy to answer them. So I'm happy to hang out for just a second. So let me see what we got going on in the chat. Okay. Oh, all right. Tracy, if you're still here, I've had tingling down my leg the whole time, and it increases with exercises, but stops after exercise. I get tingling upon standing, but it stops after walking for a little bit. So it's just pain while standing, but actually walking is okay. That's interesting. So there's a lot of questions that we could use to kind of pick this apart and see, are you doing the right thing? What are you doing for exercise? What other movements and positions irritate it? We would want to know. Well, I mean, a simple question is we could look at directional preference and we could say, hey, does bending forward or bending backwards feel worse to your body? And if one of them is clearly worse, then we can lean into the good direction for a little while. So at least we can get you active. The biggest thing that we see with people who have pain with a specific position, it's almost always, it's either sitting or standing. A lot of people, it's actually both. But if people have a real clear directional preference, then one of those two will be really painful. So either standing or sitting will be really painful, but then the other one will feel okay. So like standing feels terrible, but sitting down feels like a break, right? Or the opposite. Sitting feels terrible, standing feels like a break. If that's the case, then a lot of times we can just work on full body mobility and strength. And as we improve your physical resilience, then those positional pain symptoms improve over time. But it's not as a result of just going after it directly. It's as a result of improving your overall health and fitness, if that makes sense. Okay. Yeah, exactly. That's what I figured, that flexion was probably better for you, Tracy. If standing hurts, then a lot of times the opposite, sitting or bending forward or child's pose, stuff like that oftentimes feels better. So yeah. Next question, Tree Frog. Whoever Tree Frog is. Hello, Tree Frog. Doctor, what do you think about Low Back Abilities program? It's the only thing that's been working for me. We have an entire episode on that where I kind of debunked some of his stuff. So if you haven't seen that, you should go see that. Here, I'm actually trying to pull it up for you right now. Give me a second. Where is it? I think it's a little bit further back. It was like a few months ago. We did an episode on low back ability. While I'm looking for it, I'll try to talk and answer your question. I would agree with some things that they do, and I disagree with some things that they do. I really like that low back ability is, a movement optimist, right? He tends to, not try to scare people about their backs, and he tries to encourage using your back and improving your mobility and the strength of the spine. I think that's really good. That's really, really a good thing. Graded exposure. He tends to take one thing and break it down into smaller things that are easier and then gradually work up. That's great. I think that's fantastic. The thing where we diverge, and here, if I'm going to put this in the chat, hopefully you guys can see this. I don't know if you can see that YouTube video. That is my kind of debunk or reaction to low back abilities stuff. The problem that I have, the main problem I have with low back ability is that it's kind of, and we've had a lot of people that have come from his program, and they come to us because he doesn't have, at least currently, I'm not aware that he offers any kind of real one-on-one guidance. It's kind of a do-it-yourself experience, and it's kind of the same thing for every single person. And it's a very limited scope of exercises. It's not really a full body mobility, strength, cardio, and lifestyle changes that we need to see for chronic pain. And it works for some people, and that's great. But a lot of people need more of a diverse approach, and we need to look more at their full body mobility, strength, and cardio. And we need to look at things that have nothing to do with exercise. We need to look at stress, anxiety, depression, fear. We need to look at nutrition and sleep. And, they just don't cover it. That said, if you're curious, we actually did introduce, let me pull this up for you. If anybody's still, whoever, what was it? Tree Frog. If you're curious about this, typically, historically, we only work with people one-on-one, with more personalized programs, but we did recently, and we're actually testing this out. We did recently introduce a more affordable do-it-yourself program. That, because I know there's a lot of like do-it-yourself programs, and most of them are not evidence-based, and most of them don't actually look at you like a whole person. So here is our DIY program. Let me put that in there. We call it our basic program, or our basic version of the Beyond Back Pain program. I'm going to just put that in the chat. So if you're curious about that, it's way more affordable than working with us one-on-one. Obviously, if anybody wants to work with us one-on-one, just, reach out. We're happy to help. It's on our website, all that kind of stuff. You can book a call with me. But yeah, if you're curious about our DIY program, I just put that in the chat. And that would be a much more comprehensive solution, where we're still using graded exposure, but we're also backing it up with proper education, lifestyle changes, and full body mobility, strength, and cardio. So I would check that out. That would be my answer. Okay, next question I see. Tracy, I guess my question, so Tracy says, I guess my question is it okay to continue with my mobility and strength work as long as the symptoms don't get worse and stay worse? Probably. But then it depends on like, how long have you been doing it? How long have you been dealing with the same symptoms? Are you plateauing? Because if it's just hovering at the same level and you're just beating your head against a wall, and you've been trying that on your own for 6 months or a year or what, or even longer, if it's been going on a really long time, and even if it's not getting worse, if it's not getting better either, then you probably need somebody to take a look at what you're doing. Because most people, unless you are also trained to put together a proper, not just a mobility and strength program. Like in our program, we've had a lot of people who are personal trainers, or even chiropractors or physical therapists and medical doctors and nurses, people with healthcare experience. But there's a specific skill and knowledge set, which is how do we design a rehab program with mobility and strength and lifestyle changes. Don't forget about the recovery side of things for chronic pain. It's different than just exercise program design, right? So anyway, if your symptoms are just hovering and they're not getting better and it's been a long time, then something you're doing is probably not ideal. And it would be worth a second set of eyes on it to see what needs to change. But if you do that and you just work on mobility, you work on strength, and you just use our safe pain protocols, and it's getting better over time, keep go for it. keep doing it. If it's working, keep doing it. That's great. Like some people, here's the thing. Some people with chronic pain, it's not that complicated. Like we get comments all the time on our YouTube channel of people who I've never spoken to in my life. We never worked with them one-on-one, and they just watch a couple of videos of ours that do some myth busting, and we give them permission to go exercise, right? Because everything they've heard from their doctors is like, don't bend your spine, don't exercise, don't push it. Everything in the world is dangerous, and your spine is super fragile. And so all they did, like they watched some of our videos and they got permission because they saw the research. Obviously, in a podcast, I don't have like a bunch of prepared research. All of our YouTube videos are like that, though. Most of them, anyway. So my point is, like, if you see that and you're like, oh, wait a minute, like nobody knows what the hell they're talking about with back pain and sciatica, and everybody's been telling me that my back is super fragile. It turns out that's not true. It is safe to exercise as long as I take some reasonable precautions, and it's okay to push it even if I have a little bit of pain. Sometimes people just need a little bit of permission to go get active again, and that's all they need. And then maybe a little bit of like a little bit of guidance, like, hey, just so you know, like, make sure you work on your full body. And that's all they need, right? And that's cool. If that's the case, then yeah, get after it. But if you're trying that and it's not working, then, we're here for you. So you can always reach out to us. And then again, those of you in the chat, if you want, we have our DIY program that we launched recently. You can check that out. It's in the chat. Dennis says, pain in the hips, butt, and the back. Nothing works for me. Can't relax. Always in pain after exercises, after bicycling, etc. I'm 45 and doctors and physios telling me different things. Nothing works. No life anymore. Lost my job. I can't do things with my family. Can't play with my daughter. Yeah, it's 4 years now and it's getting worse. I am so sorry to hear that, Dennis. That really sucks. Unfortunately, we hear a very similar story from a lot of people that we work with. So at the very least, I just want you to know you're not alone in this. And that's something that we hear very, very commonly. There is a reason that chronic back pain is the number one cause of disability on the planet. Chronic back pain is the number one cause of disability in the world. And that he says, and that cracking, look above, please. And that cracking, where I don't see. Oh, I have a painful cracking, which I can repeat all the time. Left side, L3, L4. Can't stand for long. Can't walk for more than 10 minutes. Pain while sitting. Can't lie on my belly. Can't lie on my back. Okay. And okay, so it is a painful cracking. It does hurt when it cracks. Yeah. Okay. So a couple of things. Actually, I want to review what you said about exercise. Always in pain after exercises. Bicycling. Okay. All right. So there's a lot that I would need to unpack to be able to point you in the right direction, Dennis. But here's what I can say. First of all, if you ever want to just talk to me, you can book a phone call with me. There's a link on our website, or here I'll just put it in there in case you're curious. You can do this here. I'll try to make this easy for you. If anybody wants to book a call with me, there's a call. Okay. So if you're curious, all right. But I'm going to try my best to answer your questions in a limited format. Just understand it's hard without having a real conversation with you. Okay. So the biggest things that we watch out for in this situation, what you're telling me basically is actually a lot of the pain symptoms seem rather normal. Normal in our world, like back pain, hip pain, glute pain. This is like almost everybody that we work with has that same kind of pattern of symptoms. The longer that it goes on, the more sensitive it gets, the less exercise you're capable of doing. And that leads to more pain, which means you can do even less exercise because you lose your strength, lose your mobility, and that leads to more pain. The other thing that comes up a lot is the mental bandwidth, the emotional toll that chronic pain has on us. I lived with chronic pain for, very, very long time. And unfortunately, I ended up turning to some really unhealthy coping strategies, using alcohol to cope with pain, but it was obviously not productive. My point is, if we only address exercise, we don't usually have a full answer for people for a real, like lasting changes. We want to look at what we call the 4 pillars. All right. So we've got exercise, mental health, nutrition, sleep. So what we would want to do if I was having a real conversation with you, and feel free to chime in if there's anything that if you got questions, whatever, chime in, whatever you can. We would look at those 4 pillars. With exercise, the biggest thing is, are you doing too much too fast? Are you overtraining? Or are you doing too little for too long? Are you babying yourself? Right? Usually when people are doing physical therapy, physical therapists tend to baby people. They only give people core stability exercises, bird dogs, dead bugs, maybe some clamshells and some glute bridges. It's all kind of the same, maybe a plank, right? It's all kind of the same stuff. Maybe some McKenzie press ups, some back bends, some extensions. That's usually what everybody's rehab program looks like in physical therapy. So typically it's cookie cutter. You don't have somebody really taking the time to get to know you and help you personalize your exercises. So if exercise hasn't worked, it doesn't mean that exercise doesn't work. It means that somebody is not helping you to really look at full body mobility, strength, and cardio. Plus, aside from exercise, we really need to take these things seriously. Stress, anxiety, depression, fear, as well as sleep and nutrition. But the mental health category is by far the second biggest issue that most of the people that we work with need to work with or need to work on. And Dennis, you're saying both, maybe too much, too little. That's the whole thing. If we just figure that out, dial it in so you're not skipping steps, but you're not babying yourself, and we just systematically test one level of exercise, like a little bit at a time, but we're testing full body movements, all of your major muscle groups, all of your major joints to be able to do normal human stuff. We just start with really, really easy stuff and then see how you feel. Make sure that you feel okay on your good days and your bad days, that you can sustain this level of exercise without any big flare-ups. Yeah, you're going to have some ups and downs, but like without any huge flare-ups. And then as long as you can do this tiny level of exercise consistently without any huge flare-ups, then we make your exercises a little bit harder. And then we do that for a little bit and see how you feel, right? And meanwhile, we're backing it up with looking at you like a real person and, helping you with some lifestyle changes. Usually stress and fear are the biggest ones, okay? Or depression, right? Depression, actually one study found that they followed people for 3 years and they found that depression was the single biggest risk factor for chronic pain, meaning depression was more likely to lead to chronic pain than anything on an MRI. So again, I'm happy to cite these studies. I have tons of videos where we cite all these studies, but anyway. So if we can dial in the exercise so that we push you a little bit, so we're actually making some progress with exercise, but we're not pushing so fast that you flare things up, and we're accounting for other lifestyle stuff and recovery and stress and all that kind of stuff, then we can usually make some sustainable progress. Does that make sense? Did I explain that okay? Feel free to ask any additional questions. Cool. And same thing with anybody else who's hanging out here. I already recorded the bulk of what we were going to talk about today, which was disc herniations and what to avoid, just in case anybody jumped in here late. And I'm going to talk for just a second so that if you do have questions, you have an opportunity to type out your questions. But for anybody who jumped in late today, what we talked about was 5 things that you want to avoid if you have a disc herniation. Number 1 is if you have red flag symptoms: partial paralysis of your foot, incontinence, loss of control of bowel or bladder, numbness and tingling in the groin, like you can't feel it when you wipe after using the restroom, or just other really weird symptoms that just came out of nowhere, like you're vomiting all the time, your hair is falling out, fever, sweats, chills. Obviously, that stuff, go talk to your doctor. Go get it checked out, right? Obviously. But as long as the reason I bring that up is to say that if we rule those things out, we really don't have anything to freak out about. Even if you have an MRI with a serious disc herniation. Most of the people we work with have disc herniations. Actually, I think almost every single person we've ever worked with at least has a little bit of a disc bulge and at least has disc degeneration to some extent. So I don't think I've ever met a person who had an MRI report come back and say, there is literally nothing happening in your spine. Zero, right? I don't think I've ever seen that. Anyway, the other things that we wanted to avoid are don't rest, don't baby it, right? We want to use some activity. Don't push it too fast, right? We want to be in that Goldilocks zone. Don't get sucked into fear and freaking out about your anatomy. Make sure you abide by our safe pain protocols so you know how fast to push it with your exercises. And then don't get obsessed with core stability and fixing your alignment and posture and all that kind of stuff, because those things are normal, everybody's asymmetrical. Okay. Let me, Dennis, language barrier, Europe. We've worked with a lot of Europeans. You know what you could do, Dennis, if you do want to talk to me, join our free, here. We have a free community. Let me give you a link to we have a free community, and you can post there. And if I see you in there, I will unlock your ability to send me a direct message. And then sometimes it's easier to just like type it out, especially if there's a language barrier. So let me find that link for you real quick to our free community. Where is that link? Give me just a second. I see there's another question. I got you. I'll read your question in just a second. And then anybody else who's hanging out here, if you have any questions about disc herniations, chronic back pain, sciatica, fear, stress, the neuroplastic changes that happen with chronic pain, whatever you need. If you got a question, shoot it at me right now. Because as soon as I don't see any questions, I am going to wrap things up. So just give me 1 second. Okay, yeah, this will do. Here is our free community. Cool. There you go. We've got a bunch of different resources in there. Our master classes in there. We've got a bunch of different trainings and stuff. I'll go live once in a while. And then if you have questions, hopefully that worked. I don't know if that actually worked. Anyway, if you have questions, then you can reach out in the free community or, post in the forum, and then I can always, message you there. Cool. That goes for anybody. I'm happy to chat. I'm here for you. That's our whole job. Okay. Serrato. Let me scroll up and find your question. Give me 1 second. Oh, yeah, CRPS, chronic regional pain syndrome. Okay, yes, I'm so sorry I missed your question. All right, so chronic regional pain syndrome, CRPS it's a tough one. Okay, so you've got CRPS on your right foot, and you injured your lower back in February, diagnosed with a bulging disc. All right. I hope you don't mind me asking you a question, but did you actually have an injury to your right foot? So CRPS is kind of complicated, and there's some different types and presentations with CRPS. Hold on, Marshall, I'll get to your question in a minute. So right now I'm answering the question about CRPS, chronic regional pain syndrome. Okay, so CRPS is complicated. There are a couple of different types and presentations. I'm curious if you had an obvious injury. Was there a clear and obvious injury with clear and obvious nerve damage? Let me see. Yes, Achilles tendon. Did I miss that? Sorry. What happened to your Achilles tendon? Did it rupture? Did you rupture your Achilles tendon? Let me scroll up. Maybe you gave me more details somewhere else. No, I don't see anything else from you. Did I miss something? No. I'm curious if you ruptured it. Yeah. Did you rupture the Achilles tendon? Was there any nerve damage? What did the doctor say afterwards? Achilles tendonitis. Interesting. So it's not like you fully ruptured your Achilles, or you got in a car accident and your Achilles was cut by some metal in a car accident or something like that, right? It was just tendonitis. So I have a lot, actually now I have a lot more questions. I always want to find out if where did you get the diagnosis? Who diagnosed you with chronic regional pain syndrome, and why are we calling it that? Because that's a very specific type of diagnosis. And I just want to make sure that they got the diagnosis right. That's first of all. But either way, when we see chronic regional pain syndrome, no rupture, nothing cut. That's good. That's really good. It's a lot more stubborn when there is a significant injury with severe nerve damage associated with it. That's a lot harder to rehab, and that's a lot harder to figure out. But when there's no clear damage, then my question still stands. We don't have to talk. We don't have to go back and forth like this here. Same thing goes. If you want to talk about your situation, you can either jump into that free group and then send me a message, or just post in the group and we can talk about it. But I'm happy to talk to you more about this. But chronic regional pain syndrome is, like I said, very misunderstood. I've treated a lot of people with chronic regional pain syndrome, and it's very stubborn. And we need to take this, really is where we need to look at all 4 pillars, right? Exercise, or like physical fitness, mental health, nutrition, sleep. We really need to just figure out what's going on in your life, that especially if there's no obvious damage, because Achilles tendonitis is really that. If you took an MRI of 1,000 people, a lot of them if you took an MRI of 1,000 people with zero pain, a very high number of them would have Achilles tendonitis on their imaging, even though they have zero pain. So tendonitis is really not necessarily the end of the world, and that does not explain chronic pain or CRPS type symptoms. So that may be getting mislabeled. We don't know. I don't know. I'd have to know a lot more. I'd have to actually talk to you. Anyway, my point is, we still then can look at what are the things that are in your control, because the way that chronic regional pain and syndrome works is something that we actually, you should watch this. You know what you should do? Here, watch. Do you want me to give you a link inside the free group? We've got our pains. Yeah, watch this. Watch our pain neuroscience mini series. Boom. There you go. Watch that. All of that, that's all the stuff that's happening. That's a lot. Not everything, but that's a lot of what's happening with chronic regional pain syndrome. That is an 8-part mini series. I think it's 8 parts on pain neuroscience. And with CRPS, that is huge, huge. The changes that happen to the nerves for them to become really, really hyperexcitable, meaning it's easy to have pain even when you're not causing more damage. And it can be really severe pain, but a lot of it is neuroplastic changes. Okay. So we can change that stuff though. You can improve that with lifestyle changes, especially if there was no significant damage. We've seen this. In fact, if you jump into the free community, we have somebody who's in our program right now who has chronic regional pain syndrome. So if you wanted to talk to them, I could always ask them if they'd be willing to talk to you a little bit and, point you in the right direction. Okay. Any other questions? I don't know if I answered your question. I don't know. Yeah. Anybody else have any questions? Okay. Marshall. Marsha Hall. Marsha. Sorry. Marsha Hall. Marsha. If you're still here, I'll answer your question anyway. It says, is it okay to rest briefly? I'll be in motion, but get tired, or I'll be in some pain. And if I rest 5 to 10 minutes, it feels better, but sometimes start to get a little stiff feeling. Of course, it's fine to rest for brief periods. In this episode, when I talked about resting and don't rest, what I meant, and I just want to be totally clear about this, is don't take the approach where your whole rehab approach is, I'm going to just rest and not do anything ever. That's bad. Just like, I'm going to do bed rest. I am not going to do any exercise until my pain goes away. But then your pain never goes away because you never move your body. So of course, if you need to take breaks, please take breaks, of course. But just don't force it. Don't force it with the exercises, but also don't be so afraid of exercises that you never actually move your body. Okay, that's what we're looking at. All right. And Yeah, you're welcome. By the way, I hope I answered your question about CRPS. Seriously, watch that neuroscience series, and then once you're in the free community, like I said, I have to manually unlock your ability to send me a direct message. But like, if you just make a post about CRPS in the forum, then I will. I'll do that for you manually. Okay, and then we can. I'm happy to talk to you a little bit about it. Okay, we got another question. What else do we have here? Let's see here. Herniated disc in my neck makes my arm numb. You should watch. We we focus mostly on back pain and sciatica, but I've got some serious neck stuff that I was dealing with. I got slammed on my neck in my first Brazilian Jiu-Jitsu tournament, and I had a lot of radiating pain down my arm as well. There are a lot of exercises you can do for it, but let me see this. Disc herniation recovery times. This video specifically is talking about low back pain and sciatica, but I could easily have found the same research talking about cervical disc herniations, meaning your neck. So all this research right here, disc herniation myth busting. Okay. This is one of our, actually one of our most popular videos, but it's also, I tried to make a scary subject and try to make it fun, but it's also like a lot of research on disc herniations, and the same research does apply, or the same findings apply for both the lumbar spine and the neck. Okay, cervical spine. All right, S. Leon, who you just joined our basic support. Well, welcome aboard. I just can't tell who you are based on your username. So I I don't know if we've talked or not, but welcome aboard, and I'm glad to have you here in our program. As you're getting on board, if we haven't talked, then send me a message, and let's make sure that you get onboarded into the program smoothly. But yeah, welcome aboard. I can't tell based on your username who left that comment. That's the problem with YouTube. Like I want to do these live streams on YouTube because more people can see what we're doing. But if I do it inside of the Circle community, I can actually see who I'm talking to, which is nice when we have people that are in our community. So I don't know which one to do long term. Anyway, Marcia says, thank you. I got a Pronus cushion that seems to help. I'm guessing that's just like a seat cushion. Pronus cushion. Let's see. I don't. Nothing's coming up. That's okay. I'm assuming it's just a seat cushion. It helps you lie. Oh, you lie on it and you can read at the same time. Oh, yeah, sure. Okay. Any of that kind of stuff, like devices and cushions and, anything for home, just make sure everybody, that's listening here, put that stuff in its proper place. Those devices and home remedies and stuff like that, those are really just meant to be a short-term pain reliever. They are not meant to be a long-term solution to chronic pain. They're just there to make your day a little bit less miserable while you're dealing with chronic pain. But just make sure that you don't substitute like a cushion or a strap or a lumbar support or I don't know, like supplements or medication or something like that. That stuff does not replace sustainable lifestyle changes. Mobility, strength, stress management, sleep, nutrition, nervous system hyperactivation, hypervigilance, fear. Like you gotta address that stuff. All right. So just make sure that any of the home devices and that kind of stuff, we are also looking at the bigger picture. All right. I don't see any other questions. I'll give you guys just a second though. I know there's a delay between when I speak and when you hear it. I think there's like a 20-second delay. So anyway, I'll give you a second here. If you do have some questions, I'm happy to hang out for a second. I already finished talking about what I wanted to talk about today, but if you guys do have any questions, then please fire away and I'm happy to answer them. I'm just going to ramble for a second so that if you do have questions, you actually have time to type them. But then if we're out of questions, then we'll take off. I am going to try to do these things more regularly, okay? In the future. That is my goal. I want to be able to do more live streams. If you guys have like stuff you'd like me to talk about on live streams, you leave comments on any of our YouTube videos, or drop a comment into our free community, whatever you need, and I'm happy to take suggestions. Let me just 1 second here. Again, any other questions, put them in the comments, and we'll talk about anything. Chronic pain, disc herniation, sciatica, fear. Let me see here. There's just one other thing I'm checking. Otherwise, if I don't see any questions, we'll take off for today. All right. Good. Steve. All right. Last chance. Any other questions? Last chance here. Good. Yes. Yeah, Dennis, I see you. Let me get you in there. And then I think that was, that must have been Steven then who just joined Basic. I just want to know, because I was just talking to another Steven actually, recently. So I wonder if that was the same Steven or a different Steven. But if it's the same Steven that we had a lengthy phone call the other day, say what's up. When you jump in there, give me a message and tell me what's going on and how you're doing, man. Okay, there you go, Steven. If you're the same Steven that I talked to like last night, then say what's up when you get into the program. Otherwise, welcome aboard, and I'll send you a message, and we can make sure that you get onboarded. Okay. And then let's see. Sorry, let me back up here. Dennis. Can I grant access? Yes. Yeah. Give me a second here. Dennis, where are you, man? Give me 1 second. The rest of you guys, if you don't already know, we have a bunch of really kick-ass programs. So I'm just going to put a link in case you're curious about learning about our programs and you want some help. We have different levels of support. We recently introduced a more accessible version of support as well. And then of course we have one-on-one support for people with back pain, sciatica, disc herniations, that kind of thing. So if you're curious about that stuff at all, let me just drop this in the chat. Different Steven. Okay, that's cool. I'll send you a message. I want to get to know what you've been dealing with, man, and make sure that you're in the right place and make sure that you get up and running smoothly. So here is a link to our Beyond Back Pain program membership options. If anybody's curious, no pressure, but if you're curious about what we do, take a look. There you go. Okay. And then Dennis, I got to grant you access so that you can send me a message. There you go. Save changes. Boom. Dennis, you're good, man. Send me a message. Tell me what's going on. Cool. And then we had a question here. Let me scroll up. Steven says, do you think losing weight would help my low back pain at all? Yeah. Weight loss is a secondary goal for a lot of our clients in our Beyond Back Pain program. So once you get in there, don't try to get through everything all at once. It's just going to be overwhelming. But we have a massive and amazing and very thoroughly researched course on nutrition that can help with weight loss and make it not super stressful. So yeah, check that out once you get up and running and all that kind of stuff. And yeah. Yes, absolutely. And we know that that weight or body fat percentage is something that correlates as a risk factor for chronic pain. It's not the whole picture. So we don't want to make that the main objective, but a lot of people, as we get you more active and eating healthier and recovering, and if there's a lot of stress, if we help you with that, then weight tends to reduce and your body composition improves, gain more muscle, lose some fat. So yeah, absolutely. That would be helpful as a secondary goal. But the main goal is let's get you active and then make sure we address any other lifestyle factors that might be contributing to your pain. Okay. And I'll send you a message too to get to know more a little bit about your situation. All right. But welcome aboard. Craig has a question. Craig says, what about intermittent back pain versus chronic persistent pain? Have we talked before? That seems like it's a very specific question that I got a while ago from somebody on a live stream as well. Anyway, what about intermittent back pain versus chronic persistent pain caused by things like sitting, standing, These things didn't cause pain before an injury a couple of years ago. Okay. Craig, if I understand you correctly, I know movement is medicine, but sitting and standing is part of life too. Totally agree. You can't just like always be moving. You got to be able to take a break sometimes. Totally get it. So Craig, a couple of things. Is it only, are you saying intermittent? And when you say that, you're saying, I actually feel good when I'm moving around, but as soon as I just stay in one position, whether it's sitting or standing, if I just stay in one position and don't move, then I get significant pain. But if I start kind of moving around, then I'm fine, right? Is that what you're saying? If so, that's super common. And yes, we talked before, but I didn't ask this question. Did we talk? I wonder if we talked on the phone or if you were on a if it was a live stream. Anyway, the answer to your question is that's super common. Overall, we need to improve full body mobility, strength, and cardio. Focus on life. I know I'm a broken record at this point, but it really is like the only way that we can look at that is we don't just look at the sitting or standing positions. We look at the vessel. I don't know if that sounds woo-woo. We need to look at you and your physical fitness and your mental health and your recovery. In other words, how healthy are you as a human being? And as we improve that, then a lot of times, because almost everybody with back pain and sciatica says either sitting or standing or both are painful. That's like the vast majority of people with back pain would say the same thing. Now, how it manifests and whether movement feels good or not, that's a little bit different for, each person. But like standing hurts or sitting hurts or both of those things hurt for people. That's like the number one thing that people have an issue with back pain or sciatica. So yes, we can change postural recommendations and sitting environment and your chair and lumbar support. And we can do that kind of stuff. But like you should be able to just sit on any old chair for a little while, at least 30 minutes, 45 minutes, eat some dinner and not have to worry about it. You should at least be able to do that, right? So and actually you said, 30 to 45 minutes in a car. Yeah, exactly. Like you should be able to do more than that and it shouldn't be an issue. So to fix that, we need to stop worrying so much about the sitting and standing. Do what you can to make sitting and standing not as big a deal, but look at your overall physical fitness and health. Again, that's sleep, nutrition, stress, fear, anxiety, depression, whatever. Just look at you like a whole person and improve your overall health, mental health, physical health, recovery. If we do those things, and especially as we build up strength and resilience of the tissues, strength and resilience of your spine and your muscles and the intervertebral discs, and we just make you tougher and more resilient overall, then you will be able to handle more stuff in your life, like sitting or standing in one position. Does that make sense? I hope that answers your question. 4 pillars. You got it. 4 pillars. And I don't know if we haven't talked on the phone before, then feel free to, if you have, and you have my number, you can, it's a business number, but it forwards to me. So you can always just text me if you have that. Or, send me an email, jump into our free group, whatever. If you have more questions and you need some help, jump in there, talk to me, and I'm happy to help. Okay. Dennis says, got it. Mini screen on iPhone and multitasking makes it hard. Now I can't remember what that was in response to. Sorry for, here, hold on. I think I missed something. Sorry for the dumb question. Wait. Did I miss something higher? Hold on. Sorry for the dumb question. How can I find you to send you a message on the website? Yeah. You're fine. Dennis, here, I'm going to make it really easy for you. Give me 1 second. Dennis, message. I already had you pulled up, Dennis, in our community. So I'll just send you a message real quick. Hey, Dennis, it's Dr. Davis. Let me know what's going on, and I'm happy to help any way I can. There you go. Done. You now have a message from me. I hope that made it easier. Okay. Let me make sure. Yeah, you should be able to Message me back. You're good. Oh, it's not disabled on my side. It says you're good. Disabled direct. No, you're good. You should be able to send me a message just fine. I don't know. Refresh your screen or something. I don't know. I'm looking at the settings right now. I swear it's okay. Oh. Well, this is embarrassing. Technology is hard. I'm going to give you a second, Dennis. Try to just like refresh your page and try again. It should work. It looks like the settings are fine on my end. Yeah, you should be good, man. It's the Big Toe email address. I'm not going to say your whole email address live, but if that's the right one, then I've got you, and you're good to go. I just sent you a message. Okay. If it's an issue, then just like send me an email. Here's my email: Anthony@shapeshiftwellness.com. All right, there you go. If there's an issue, whatever, just send me an email. That works too. And then we'll sort it out. Stephen, have I heard of HLA B27? Could that be part of the reason for my chronic back pain for 10 years since I was a teenager? Most likely not. Probably not. I wouldn't. Yeah, Dennis, cool. You got that sorted out? Good. All right, Stephen, HLA B27. Don't waste your money. Peptides are silly. They're just expensive placebos. They don't really do anything. We've got research on this. It's not really helpful. Yeah, don't waste your money. And then as far as like, could that be the reason? No. Focus. Chronic back pain, chronic pain, sciatica cannot be blamed on one thing. So you could ask me anything. Dr. Davis, is it, HLA B27? Is it this peptide? Is it this hormone? Is it this joint? Is it this muscle? Is it this nerve? And I would say, maybe that's a very small piece of the pie, but like, what's the rest of the pie? And usually what we see is, yeah, look, genetics are part of it. Sure, absolutely. Genetics are a risk factor for chronic pain, but not everybody who has the same genetics has the same life and health and diseases and injuries or chronic pain. Why? Because of the lifestyle that they're living. Right? The things so we have, in health and disease prevention and stuff like that, we in epidemiology, we look at, modifiable and unmodifiable risk factors. Okay. Unmodifiable risk factors for chronic pain are the things that people are most worried about, which doesn't make any sense because you can't modify those things. So your genetics, the things that you see on your MRI, your disc herniation, degeneration, stuff like that, you can't do anything about that. But this is what people spend a lot of time freaking out about. You can't do anything about it, but that's okay, because those factors only represent a very small portion of the pie. So yes, they represent some risk for eventually developing chronic pain. But if we then instead focus on all of the modifiable risk factors, which I just call it the 4 pillars, not because I'm, it's some proprietary perfect technique. No, it's just like, I'm trying to make it simple for you, right? Exercise, mental health, nutrition, sleep, the basics. Take care of yourself. Do it in the right amount, in the right order, right? Yeah, I know there's a lot of questions like, well, which exercises? How often? When do I progress? Yeah, I get it. But like, make it simple. 4 things. Exercise, mental health, nutrition, sleep. Focus on those things, and then we probably don't have to worry about the genetics and the asymmetry and the disc herniation and all that kind of stuff. Right? All right. I hope that answers that question about that. Cool. Dennis got it figured out. You're good. Oh my God. I am so, what was I thinking about? I am so sorry. Stephen, good God. I was thinking, what I was thinking about is, what is the peptide? BPC 157. BPC 157. I'm so sorry. HLA B27 is a gene related to arthritic changes in rheumatological conditions, right? So that is something to, and now, let me just make triple check. Oh yeah. Exactly. Okay. Yeah, exactly. I'm sorry. There are a lot of like 5-letter number combinations involved in both the gene world and the peptide world. So I apologize for that deeply, Stephen. So I'm assuming if you know about that, then you've already seen a rheumatologist and they've already tested. So then the question is, do you have something like rheumatoid arthritis or something like ankylosing spondylitis? Have you been diagnosed with any of those conditions? So sorry about going on a rant about peptides. All of that stands true. I apologize. Again, letters and numbers mixed up. So yeah, I was thinking about BPC 157. Sorry about that. Anyway, HLA-B27. So you'd go to a rheumatologist and they would evaluate you for any of those conditions. So that's the question that I would ask is, do you have any of those conditions? And then if you do have something like rheumatoid arthritis it's the inflammatory arthritides. So things like psoriatic arthritis and ankylosing spondylitis, stuff like that. If you have those genes, then it definitely is a risk factor for chronic pain. But then actually it still goes back to everything that I just said. So everything I just said still applies, even if we have a gene that predisposes us to reactive or inflammatory arthritides, right? Like we still say, well, what are the things that you have within your control and what are the things that you don't have control over? And then we just focus on the things that you have control over. Does that make sense? And so still it comes down like, as far as what we would do is how much can we do by looking at controllable factors like lifestyle changes, right? And then if you needed to talk to a rheumatologist about medications, that's a conversation for a rheumatologist, right? I mean, it's okay. They can work together. It doesn't have to be all like some people, most people can make dramatic changes in their symptoms by just looking at lifestyle changes. But some people do need additional support, right? Some people do need additional help with, surgery or medications or, other types of interventions. Our job is to try to help people with all of those non-surgical, non-drug paths to maximize the modifiable risk factors. Cool? Stephen. hopefully you didn't just disappear because I read one number wrong. that would be embarrassing. So anyway, any other questions, guys? I'll hang out for just like 1 second. If there are any other questions, I'm happy to answer them, but yeah, go ahead and let me know. Otherwise we'll take off for today. I'll have a sip of water and then give you a chance if anybody has anything else they want to add or anything they want to reply to. Psoriatic arthritis. What was the song from our board examinations on that? Silver scales, pitted nails, and it occurs on extensors. Psoriasis. Anyway, not the same as psoriatic arthritis, but anyway. Okay, guys, I don't see any other questions coming up, so I guess we'll take off for today. I am planning on doing more live streams, so make sure you're subscribed to the channel if you want to get notified when we go live, and then we're here for you. We're here to help. And, hope that worked. That's it. We'll see you guys next time. Take care.